just now about the really easy topic of language. And it was so easy we were finished late. So I'm sorry to keep you all waiting, and appreciate Farhana and Dr. Khan and Rosario also waiting. If you're joining us online, welcome to M3 here at the UN in Vienna. And we're here for an important topic, which is, in this world of innovation, you might hear a lot of bad things said about technology. Who has bad things to say about technology? Now, I'm partially sighted, so if everyone's raising their hand, I see nothing. So I assume the answer is zero. We wanted to spend some time in this session to think about technology as a tool. And just like language, as we discussed in the last session, language is also a tool. And a tool, if you think at home in your toolbox, you might have a hammer. And when I go to hammer a nail, it is quite difficult because I can't see the nail. But with a little bit of practice, you know, hammers work really well with nails. But try to take a hammer to a screw, and what happens? It doesn't work. And so if we think about technology as a tool, there are things that it can really help us with. And also there are situations when it can actually be ineffective and inappropriate. And so what we want to do in the Zero Project, in the is to make sure to hold space for more dualistic thinking, more dialectical thinking. What I mean by that is that we acknowledge the reality that at the same time, there are tools with very positive impact, and innovative examples of that we'll see today. And also there are some tools that are destructive, and we've had many sessions and discussions lined up for AI and the challenges with AI in terms of inclusion. AI also has some potential benefits. So we want to make space for that dualistic thinking that, you know what, there are tools available to us, tools that we build, and we can put them to good use, or we can turn them into tools that are disconnecting, that are barrierful. And in this session, we particularly want to highlight technology that is enabling. For Martin in the open is innovation, impact, and scale. And with me on the panel this afternoon, we have great examples, in fact, awardees of this year's Zero Project, of how technology was used as a solution to improve the accessibility of healthcare, to improve access to healthcare around the world. So before I introduce the panel, I just want you to think for a moment, if you'd like to close your eyes or just visualize this. Many of us have been in a diagnosis situation once upon a time. I can remember when I was diagnosed with a genetic condition that is decreasing my vision over time. So if you happen to have had a diagnosis experience, where was that? How did you get there? How comfortable, uncomfortable was it? Who was with you in the room? What language did they use? What level of professional skills did they have? What expertise was available to you? And I'm sure across the room, we all have different answers to that. Some of us have had an easier time accessing healthcare, some of us less easy. So all these barriers that arise in the physical space, in the built environment, in technology, in socioeconomic status, to name a few, these barriers are very real. They're very real. And so in today's session, we're going to explore in our own way here the context of sight loss and thinking about vision. How do you get to a specialist? How do you get the diagnosis? How do you get your eyesight checked when you're in a remote place or a place that isn't in the city, or perhaps there are other constraints that prevent you from accessing the eye hospital, even there isn't an eye hospital. So we'll start in a few moments with Peak Vision from the UK, who are 2026 awardees. And I'm delighted to introduce Farhana to my right. Farhana Rehman Furs is the Global Head of Partnerships at Peak Vision, based in the UK. And Peak Vision is a not-for-profit social enterprise that is dedicated to vision and eye care and vision health for everyone. And we'll hear more about the successful app that was developed to reach people not able to access eye care. And joined with Farhana is Dr. Asad Khan from the Mayo Hospital in Lahore, Pakistan. And Dr. Khan will be sharing with us a real example of what was innovative, impactful, and change-making in this project. And then afterwards, we have Rosario. Rosario Urdanivia is from Peru and will be sharing with us the innovation that won an award this year from Oír para Crecer, looking at hearing and audiology. So Rosario is the executive director and will be sharing with us the journey that the organization went through to bring something very innovative to rural and remote parts of Peru to help overcome barriers to access. So we would love to hear your questions. So please, as you hear the presentations, think about questions in your context that might be interesting for you to ask at the end and helpful for all of the audience. And we'll have some time at the end for Q&A from the floor. So can I start with a huge round of applause for Farhana and Dr. Khan on the success of the award and also for what they're going to share with us now from Peak Vision. Thanks, Farhana.
Hello, good afternoon. Thank you so much, Brandon. It's so lovely to be here. My name is Farhana Rehman Furs. I'm the Head of Global Partnerships at Peak Vision, and I'm here with my colleague, Professor Asad, who's representing the College of Ophthalmology and Allied Vision Sciences, as well as CBM Pakistan. I'm delighted to introduce you to Peak Vision. Peak is a not-for-profit with the mission to strengthen eye health systems and service delivery through digital innovation. More than 1 billion people worldwide live with avoidable sight loss and blindness, and that number is rising. 90% of those people are located in low and middle-income countries. Most simply need just a pair of glasses or a very inexpensive and short cataract operation. We believe that everyone should have access to good vision and eye health. Our software and data insights are helping to achieve that with an end-to-end solution designed specifically for eye health. Sorry, there should be sound with the video.
In spite of tremendous efforts to turn the tide, the number is growing. More people are held back in school, at work, at home. But how do we reach everyone? Some can't make the journey to care, or don't even know a solution exists. Many are missed through fractured health systems and don't even show up in the data. We need to work smarter to make the invisible visible. That's where Peak comes in, powering our partners with technology to enable anyone, anywhere to be screened, analyzing data intelligently to spot shortfalls, and monitoring patient journeys to care so no one is left behind. And it means that when we succeed, we can reach everyone, unlocking the potential of millions.
We have developed a clinically validated vision screening app that has data capture and referrals. The app can be used by any adult who can operate a smartphone. That means people like community health workers, volunteers, and teachers can successfully identify people with an eye health need. And that very importantly helps with task shifting, ensuring that non-eye health specialists can use our app. The software can be used in many different contexts. It can be used to screen children in schools, community members, near their homes, and also at the doorstep. So household, we can go in remote and rural locations, identifying people who normally wouldn't be able to travel to health facilities or may not even know that they have a health issue. Many people who are living with cataract and have been blind for many years may not be getting the care that they need. The software allows for secure and simple data capture, and when the patient is identified with an eye health need, they are referred on to the follow-up care. We enable that through SMS and WhatsApp messages, and we ensure that these reminders go regularly. However, screening is just the beginning. We really want to know who is attending, but more importantly, who is not attending. Real-time program data insights can be used by program providers to identify equity gaps, understand barriers, and improve attendance to appointments. These powerful data insights can be used by program managers to make better use of their resources and, very importantly, minimize unnecessary referrals to hospital care. The result is that more patients can be treated at the primary level and that specialist resources are kept for more complex cases. Today, our partners have used PEAK to screen 18 million people, and they have connected 1.7 million people to care. Christian Blind Mission was the first to use PEAK in Pakistan back in 2018. Today, we work with many different NGOs, including Sightsavers, Fred Hollows, eye hospitals, and governments across 13 countries. India, Pakistan, Kenya, and Nigeria are where PEAK is being used at greater scale, and I'm very pleased to share that our ambitious goal is today we're reaching 1 million people every 2 months, and in the next 3 years we want to be able to reach 1 million people per year. Thank you.
Thank you, Farhana. Congratulations.
Thank you.
A lot of evidence of scale and that innovation and that impact being able to translate. So as you think of your own context, folks in the room, many involved in healthcare delivery, population health, these are bright spots on the horizon. How to leverage the power of technology, as Farhana shared, how to reach more people for whom there are access barriers, and using technology in such a powerful way. I wonder, Professor Khan, would you like to share from your perspective?
Yeah, thank you very much. I'm Professor Asad Aslam Khan. I was the former National Coordinator for Eye Health in Pakistan. I'm just going to share our experience in Pakistan with PEAK. During the last 25 years, we have upgraded all the tertiary hospitals, district hospitals, and sub-district hospitals. But our real problem was the referral chain from the community, from the basic health unit to the already established facilities. With Pakistan, with a population of more than 240 million, currently with the ratio of 1:10, there are 26 million people, those who are either blind or visually impaired, and out of these, 1.5 million, they are blind. And this blindness is depriving the patient from earning, learning, and well-being. And if we talk about on economical basis, we have a financial burden of rupees 2 billion per year because of this blindness. We are lucky that PEAK, the CBM chose Pakistan as the first country where we implemented this portable eye care device, portable eye care system in one of the village in province of Punjab. And initially we started from one village in one district in Punjab, and now this program is being run in 3 provinces of Punjab, Pakistan. And during the last 6 years, 7 years, we have trained more than 1,800 AD health workers, primary healthcare workers, and we have linked about more than 380 facilities, right from the basic health unit, rural health centers, to sub-district, district, and tertiary care hospital. And with the help of this peak technology, we are screening the patient, the masses, communities at the community level, door-to-door surveys, and in school. And the result is that since 2018, we have screened more than 7.8 million people. And out of these 0.7 million, they were found with unmet need. And more than 0.5 million, the people, they were connected to already linked facilities. And currently, we are screening around 200,000 people every month in these areas where we are using peak technologies in 3 districts in 3 provinces of Pakistan. And a third-party evaluation was performed, independent of the overall project, and we found that with the help of peak, we are screening 2.5 times more people as compared to non-peak technology, and 16 times more people, they are dealt at the facilities, at the rural health centers, at the sub-district Tehsil headquarters hospital, and the district headquarters hospital. And the cost of their treatment is 6 times lower as compared to areas where the peak technologies were not used. And this has brought a revolution, because the main problem is we have to make the screening person comfortable. Our primary healthcare workers, the daily health workers, they feel so comfortable with this portable eye care technique that they can easily screen the masses in the community, in their door-to-door house visit, and in the schools. And they have found so many people like Muhammad, who was working in a village, who was the breadwinner of his family, but he had headache, he had refractive errors, but he couldn't afford to go to a nearby sub-district hospital, which we have already established. So this lady hair workers used the peak technology. He screened this patient Muhammad, and referred him to rural health center, where the optometrist was there. The optometrist, he examined the patient and prescribed him the glasses. Now he is very happy. Without any headache, he can see the people, the thing very clearly, and he is motivated, and he is a very well a productive person. The impact of this simple technology is that previously the sub-district hospital and the district hospital, they were burdened with refractive errors. 51% of patients who had refractive error, they were simply referred to district and sub-district hospital level. And the district ophthalmologist, instead of curing the patient by doing the cataract surgery, diagnosing the patient for glaucoma, diabetic retinopathy, he was busy in refractive error, management of refractive error. With the help of peak technology, screening at the rural area, community level, referral to the rural health center where the optometrist is there, 51% of the patients now they are being tackled at the rural health center for refractive errors, and the productive rate for cataract surgery increased by 50% at the district and sub-district hospital level. So this is the impact that the ophthalmologists are now, they are catering more causes of blindness rather than simply handling the refractive errors. Now coming to the real problem of sustainability and next step. I have over 40 years of experience in ophthalmology. I am involved in prevention of blindness project for the last 28 years. I have implemented so many projects, I have seen so many innovations, but believe me, I haven't came across a device like Peak, that it is so easily acceptable by the user, the ready hair workers, that it has made our life easy, that was our big dilemma, that how to reach the unreached people. With the help of Peak, we have reached the unreached people. Now the people, they are screened at the community level and they are simply referred to rural health center for the refractive errors, and rest they are referred to DHQ, teaching hospital for the management. We are engaging the government that this peak technology will solve their problem of health management information system, and with the help of, and we are motivating the government because of our advocacy. One of the province of Sindh, they have deployed the optometrists in all the rural health centers and basic health units, and the patient, after screening by peak in the rural areas, the communities from by the ready health workers, they are being referred to rural health centers and basic health units. And now we are convincing the other provincial government, Punjab, Sindh, NWFP, and Balochistan, KPK, to have optometrists deployed at rural health center so that the patient can be tackled here. One step more, then we are now going to use AI technology so that the patient, the daily hair workers, when she detects with the help of peak, detect the cataract, it is automatically, instead of going to rural health center, through the peak it will be going to the treatment center of the district headquarters hospital and teaching hospital. And we are trying to have a local adaptation, new approaches to support local ownership. We want to involve the philanthropists, local NGOs to go for this project, help us so that we can screen more and more people. Thank you very much.
Thank you, Dr. Khan. And Farhana, huge congratulations on the award. And I was struck by the example of Mohammed that you shared a story, and I just imagined how my path in this journey of diagnosis and the story you shared about Mohammed, it makes it very real. So whether it's eye health that anyone in the room is working on, or any other disability scenario or health condition scenario, these are some very real world examples, real lives that are being changed thanks to how the Peak app is being leveraged with, and we'll come to that in the questions, potential for the future and thinking about sustainability and especially advocacy, which is a huge part of the effort for funding. Let us turn our attention to Peru. So we have Rosaria Urdanivia, who is Executive Director at Oír para Crecer. And Rosario, would you share with us, please, the work that you've been doing with the organization around teleaudiology? And again, huge congratulations on your award this year.
Thank you very much. Well, I am Rosario, I am from Peru. As you heard before, I'm really happy to be here today. I'm going to share a little more about Oír para Crecer, Here to Grow, actually in English. I am a Spanish speaker, so if something is not clear, if because of my pronunciation, don't worry, it's me. I can see my presentation, so please, if you can share. Thank you very much. Well, Peru, it's a beautiful country in South America and with amazing food. And Oír para Crecer is a non-profit organization. We work since 2016, and our main strategies are in prevention, promotion, diagnosis, and treatment of hearing health. Our main activities are in screenings, diagnosis, and access to hearing aids. We are screening more than 103,000 people. Most of them are children. We feed over 4,500 hearing aids, and we are working across 7 regions in the country. And why we exist? The big challenge in Peru is the gap in hearing care. Since 2013, we have the Universal Newborn Hearing Screening Law, but it's not implemented in most of the hospitals. So it's difficult to have an early diagnosis. And also, families, especially in rural areas, face high cost and no services in their own cities. We are only 14 audiologists, I am one of them, and 1,200 ENTs. So we really need professionals and decentralize our services, because most of the hospital and services with audiology is centered in the city, in Lima. So which is our solution? Well, our solution is centered in 3 principal strategies. The first one, it's about building capacity in the different regions. Decentralize the works and activities about audiology. The second strategy is using technology. We are working with hearing aids, with Bluetooth technology, and other one that doesn't have that technology exactly. And the third strategy is the teleaudiology. Exactly what we are doing now is to fit and make the follow-ups of the hearing aids with Bluetooth. This is not something that we develop. There are many brands that work with Bluetooth technology. So what we are doing is to connect directly with these hearing aids. As you see in the pictures, we have 2 options: to connect directly with the patient that have the hearing aids, and we make an audiology session, our follow-up session, or in the case they have other brand of hearing aids that doesn't have that technology, we use available technology as AnyDesk or TeamViewer to make the support to professionals in these local, in the provinces actually. So no travel needed, faster and more consistent follow-up. But what makes this innovative? We combine technology, community, and professional training. We work across hearing aid brands. We don't work with any specific brand. We include remote monitoring, adjustment, and data use. We collect data. Technology allows us now to know about the data logging, how many hours the patients are using the hearing aids. So we use that information to use different strategies to improve the training with professionals and to improve the support with the families. Everything that we are doing is with teleaudiology. Our hands are the professionals or technicians in each provinces or with each local partners. Decentralized approach in a low resource context. So until now, since 2022, until last year, we feed more than 750 people with hearing aids. We increased the number of the follow-ups, with the remote follow-ups, 350. We covered 5 regions in Peru, the principal regions. We trained more than 15 professionals and technicians, and we supported more than 300 families with remote support delivered. But actually, this is not the real impact. The real impact are our patients, our families, our histories. And here are Lucas and Valentina. We have the consent to show the photos. They lived in the north of Peru, actually like 70 hours from the city. And they received their hearing aids 6 years ago. Now he's 16 and she is 14 years old. Lucas said, my hearing aids changed my life. Without them, I wouldn't have been able to learn everything I know today. This year, he started university. And in the first picture, we saw how we can make the follow-ups with him. And that's the idea, to come more people and to make closer with them. Financing and sustainable. We are 65 covered by donors. This number is because the hearing aids are donated to our users. We have 3 principal donors, and 35% are covered by low-cost services. We believe that it's important that families empowered about their services. That's why they have a social cost about their services, and that allow us to continue this project, not only thinking about donors, it's about thinking about local partners and how they can reinvest this income. All services are working with OPC team, but we're working with local partners about infrastructure, tools, and stuff in the place. So what's next? First, we're going to consolidate in 3 principal regions. We know that we're in 5 regions, but what we are going to do in the next steps is working closer with the government. The idea is to include our model, OPC, or Ir para Crecer model, into government system. Now we're working with Health Ministry to start this training with local professionals and to standardize the audiology training for professionals in public universities. We're starting in the first university with professionals in speech language therapies to make the degree in audiology, a 2-year degree. So we can increase the professionals, but also to increase the training with technicians, consolidate partnerships, and to increase our beneficiaries. So thank you. This is our website where you can know more about us. Oh, there's not any more. Okay, here is my contact also. Please feel free to have any question about our project. Thank you.
Thanks, Rosario. Many congratulations for the award this year, and hopefully that is inspiring you all to learn some of the lessons of what it takes to go from idea to implementation, and the examples of eye health and hearing. We have some questions that we've prepared that we wanted to dive into, which is around what next. So Rosario just asked that question. It's such a powerful question, right? We have the big splash, we have the initial rollout, we have the initial scaling up, but there's lots of headwinds. Many of us know there's the challenge of public policy, government support, there's the challenge of competition. In some cases, there's commercial factors at play. We have to think about what's unique, and we also think about the long term and how we could spread these innovations to other countries. So I might start with Farhana and ask, for the case of the PEAK app, there are other digital screening tools around. How might you describe the differentiation? What's unique about the PEAK app compared to what else is available?
Thanks, Brendan. As far as we're aware, we're quite unique in 3 different ways. So one, as I mentioned earlier, we have a clinically validated distance and near vision app, which any non-eye health professional can use, even offline. The second thing, and very importantly, we're the only providers that have the end-to-end solution where we're tracking patients throughout the entire referral pathway. So from screening to referral to primary, secondary, tertiary care, as well as to optical stores. So that makes us quite unique. And thirdly, I would say, is our SMS and WhatsApp reminder messages. Those have proven to be very, very effective in ensuring that people attend their referral appointments, and also to really help understand the barriers that people are facing to make those appointments. So it's really about finding those people that normally fall out of the system. We're very pleased about that. And I think just a final note about why we're also unique. Although we're a relatively small team, we have an incredibly strong development team that we have in-house. We have public health experts, eye health experts that work with PEAK, and we're continuously evolving the software based on the feedback from our many, many users across those 13 countries. And so the product is continually evolving. There are new features underway. As Professor Assad mentioned, we're working with AI regarding cataracts. We're also developing something called a presbyopia calculator, which has now enabled any community health worker to be able to reliably distribute ready readers at the doorstep, and many, many more features that I could speak about for a very long time. So that's what we love about PEAK and about working at PEAK, is we're constantly evolving the software, and it's specifically for eye health. Thank you.
Thanks, Farhana. And it's actually a great reminder for not just the exhibitors outside, many of whom are entrepreneurs, but in the room here, when we're working on our own initiatives and thinking what else is out there, knowing the differentiation is really critical. So, okay, it might be a lovely idea that any of us have, we see a problem, maybe it's a personally experienced gap in the marketplace or in the patient pathway. But just because we have an idea and we get excited about it, it doesn't necessarily mean that it's going to be the most scalable, the most impactful. And so linking back to the real patient experience and in the ways you've described the whole journey of care, which is more than just the initial diagnosis. So thank you for that. And perhaps a follow-up for yourself or Dr. Khan. So we heard earlier in the context of Pakistan that advocacy with the government and the different regions of Pakistan, how important it is to advocate, how important it is to educate. And I wonder how might folks in the room or those listening think through the influence of government in any context they're working in. Perhaps Dr. Khan, you'd like to go first, and maybe for Hannah.
Yes, thank you very much. This is a very relevant question, and I wanted that this should be asked. If we go back to 1998 for Pakistan, and there were no posts about to talk about optometrists. There were no post of optometrists. No cadre of optometrists ever existed. No ophthalmic technician, no ophthalmic nurse, no orthoptist, no ophthalmic technologist. And we did a lot of advocacy, and the government, and we provided the government the evidence of other countries, the impact of creating these cadres and upgrading the district health eye department. And today, now we have more than 2,200 optometrists in Pakistan, more than 1,500 ophthalmic nurses, more than 4,000 ophthalmic technicians, and they are all deployed at all levels of healthcare, teaching, district, sub-district. Only rural health center is left. So we are thinking for advocacy because it is not giving some instrument to an ophthalmologist or an optometrist or a radial worker. It is the acceptance by the service provider, whether they can accept or not. Lady health workers, they are not educated. They are below 10th class or maybe middle class. Acceptance by this of a tool which they can readily, very happily use, this is what matters to us. And we are going to show the impact in the 3 districts in 3 provinces of Pakistan to the government. And based on these success story, we are very hopeful that government will create the post of optometrists at the rural health centers, and they will use the peak technology one day for ophthalmology and similar techniques for other disciplines of disability in Pakistan.
Thanks, Professor Khan. And a really good reminder to us that the idea is not enough, that we need the evidence, and with evidence, we're armed for the conversation. And then hopefully with that progress, we can show other governments and in other countries, this is the real change that happens to lives, and also economically, or whatever the persuading factor will be, depending on the context. Thanks a lot. Rosario, we have folks probably watching and in the room wondering, how might they go about leveraging this kind of approach, the teleaudiology approach? How might others in other countries take advantage of this innovation that you've won the award and highlighted for us today?
Okay, our model, the model of Oír para Crecer, is designed to work in different places as provinces. So it has experience how to develop in different scenarios. The model is designed to work with building capacity, local capacity, training professionals for each region. The other strategy is to work technology. We work with available technology. Doesn't matter the region or the country. We work with AnyDesk, with TeamViewer, with Bluetooth, so it's possible to use in different contexts. And finally, this strategy make this project sustainable, because all the tools are available. So that's why this can be available for these different countries, for these specific things, right? The building capacity and the technology that it's available. Yes.
Thank you, Rosario. And in terms of the funding model, how important were donors and the money obtained from that revenue source or that funding source? How important were they, and how might other funding sources be tapped into to sustain this over the longer term?
For the sustainable, the different services that the local partners bring generate an income that allows that all the services that we bring or they bring are sustainable. About services, about hearing aids, yes. Now we are working with donors. We present our project and receive financing specifically for the hearing aids. But about the models and services, the teleaudiology, it's auto-sustainability, also working with the government. Yes.
Understood. Thank you, Rosario, for that. So I sense people in the room are bursting. Who's bursting? Bursting with excitement, bursting for some food, bursting with questions. We're nearly at lunchtime, but before we draw the session to a close, we want to give you a chance to bring your questions to the panel. So I think there is someone that you can see and I can't, available with a microphone. So if you have a question, please raise your hand and a microphone will come to you. Farhana might tell me if there's any questions.
I want to give a tip to the youngsters.
Oh yeah.
I want to give a tip to the youngsters.
So
A tip.
please go ahead.
I can see a lot of youngsters sitting here and they will be making so many projects. When you go to the policy makers, don't talk in their language, according to their mind. When you talk to kids at home and elderly people, they talk to their grandchildren, they talk about the toys and the cartoons. Similarly, when you go to the politicians, to the bureaucracy who are policy makers, talk to them in economy. When we took our first project of eye health to the government of Pakistan, it was worth 2.8 billion. The only question they asked, what is the benefit? So instead of saying that there are so many cataracts, there are so many glaucoma, so many refractive errors, I said only one thing, that the burden of blindness in Pakistan is 8 billion per year. Wow. And the answer was the approval of the project.
Wow.
So we will take this project as well. The burden of blindness in the community level, because of simple refractive error, this much, and hopefully it will work.
I love that. The cost of disability and that persuasion piece. So this is a whole session on its own. When we find ourselves in an advocacy situation, of course, we would all like to think that we're right. You know, who can argue with better hearing, better eye care, better sight? I mean, who can argue? But as you said, Dr. Khan, we need to do our homework to see what is the button that we can press in that conversation that is going to work. And now we want to be authentic, right? We don't want to play these, the other games that we don't like, let's say, but we want to be authentic to ourselves. So we're not going to say absolutely anything, but that's such a powerful thing to say. And so doing our research before we go to those meetings to figure out if there was one button to press, what is it? What is the language that will get through to that stakeholder so that they will write the check or approve the program? And so long as we can be adaptable in that way and still be authentic to ourselves, then we might start to open more doors. Thank you for that. I think there's a questioner down the back, so when you get the microphone, if you could tell us your name, where you're from, and we'd love to have your question.
Some short information. Please use the microphone on your table. Just press the big button in the middle and then we can save some time. Thank you.
I'll just jump in. Okay. I was interested in how you deal with the next problem. So you solve the first problem of identifying people who need audiology or eye health care, but then more people get stuck at the next thing. So in the UK, we have a problem with, for example, prostate cancer checking, where many more people have gone for prostate cancer checking, which is brilliant, but now the health service can't cope with the scanning of the people who have been identified as possibly needing scans. So how do you deal with the next problem? Do you deal with it through advocacy with government, or do you increase the scope of the work you do?
That's a brilliant question. Let's call it the stampede question. What happens when, I guess, for Hannah or Dr. Khanna or Zara, for any of you, what happens in that really lovely problem to have, but a very real problem? There is a sudden influx, growing demand. It's the classic startup challenge, which is we get too big too quickly and we can't cope. What advice would you share? How have you thought through that risk?
Thank you very much. Solution must be in place before you start tackling the problem. In case of Pakistan, fortunately, we have provided every type of facility to our teaching hospital, to district hospital, to sub-district hospital, not only by providing them the technology, but also providing them the trained human resource, in addition to ophthalmologists, trained optometrists, trained ophthalmic technician. And because of this, when we are referring the patients from community to these centers, so they are already ready to accept this burden. Rural Health Center is accepting the burden of refractive errors, and the teaching sub-district and district hospital, they are ready to accept the patients of cataract, glaucoma, squint, diabetic retinopathy. So solution is in place before we have started screening the problem.
And I'll just add that this is a very important year for eye health. The eye health sector and the International Agency for Prevention of Blindness is bringing together government decision makers at the end of this year to really advocate for an increase in the eye health budgets, but also eye health friendly policies. And we're going to be talking to them using some new research about the case for investment in eye health. And the research has shown for every $1 that is invested in eye health, there is a $28 gain for the government. And that comes from employment, education, freeing up caregivers. So we have a really strong case for advocacy with the governments, because ultimately the next problem really is exactly as you said, we need to have more services available and more accessible. Thank you.
Yes, I just want to add about hearing in my country. Yes, that's not possible that we can make everything. We are not the solution. We are the part or the way for the solution. And to bring these tools or these ideas or these strategies for the government, how we can make this sustainable and scalable with them. So yes, we're pretty sure about it. It's not possible to see all the people with hearing loss in Peru. That's not possible. So yes.
Thank you very much. So I'm to break and go for our lunch. So the condition is the most massive cheer, applause and stamping of feet for our awardees and for all the beneficiaries of their success. Thank you. Oh no, I really wanted to get your name fully pronounced.
You did it beautifully.
Is it
I
all
was
right?
so
I was thinking it
impressed.
needs to be really
Maybe it's
sharp.
a first ever.